you so much, Dr. Misra. I'm Margot Kushel from UCSF. And I tried to pepper this talk with a little bit more, not only about what we found, but how we did it, which I thought might be of interest to some folks from Epi and Biostats. And feel free, I will take questions at the end, or you can pop them in the chat. This is one of our remarkable Hope Home participants. And what another of our participants said one day really keeps me up at night, but also motivates me to do what I do. This is a 55-year-old woman experiencing homelessness in our study who said, I'm old and I'm tired and I got my disability. I can't do it no more. This is the other number that keeps me up, 580,466, which sounds a little bit like some lyrics from a Broadway musical, but instead what it is the result of the nightly count, the one time a night point in time count of people experiencing homelessness in the US. This count is done every other year by mandate of the federal government. It is quite limited in many ways. It's a visual inspection of people who are unsheltered done by volunteers. So they have to make a guess, is this person homeless? They look in a tent and make a guess how many people are in there. An account of everyone in homeless shelters. It generally leaves out people experiencing homelessness in institutions, misses people who are couch surfing or doubled up. It's probably not accurate, and is also a point in time count. You'll hear this number in the press a lot, by politicians a lot, of the number of people experiencing homelessness. And it's important for us to realize it's an important number because it's comparable year after year, but it is not either everyone experiencing homelessness that night for lots of reasons of its flaws, nor is it a real count of the prevalence, the annual prevalence of homelessness, which is estimated to be 2 to 3 times higher. So in this talk, I'm going to talk a little bit about why is the homeless population aging, introduction to the Hope Home study, the demographics of people experiencing homelessness in Oakland, pathways into homelessness, health status, health service utilization, mortality, talk a little bit about some methodological considerations, and then end, because the talk can be relentlessly depressing, talking about some interventions and solutions, or where we go from here. Oops, and now my slides are not. Okay, there we go. So the first thing, I want to actually pause and start with a question, or maybe problematize a question for you, which is you'll hear people say either, why are so many people homeless, or why, and people will just say, why are so many people homeless, or why are people homeless? And I'd like to posit, and this is in a book by Mary Beth Shin and Jill Kadori, which I strongly recommend in the midst of plenty, that there are really two questions in that. Why are there so many people in this region, in this state, in this city that are homeless? And then that is a different question from why is this particular person experiencing homelessness? I think in some ways there are two frameworks to think about that. This is a framework put out by Marty Burt and Loudon Aaron in a book published in 2001. That talks about homelessness as an interaction between structural factors, so affordable housing, how wages are for low-wage workers, income inequality, racism, and individual vulnerabilities, things like mental health disabilities, substance use disorders, and adverse childhood experiences, which place people at higher risk of homelessness, and the presence or absence of a safety net. And they note that the less favorable the structural factors and availability of the safety net is, the fewer individual vulnerabilities one needs to become homeless. If you ever get to travel, let's say to Northern Europe, which is a place with a very strong safety net, but also really favorable structural factors. They've got, state-supported housing, affordable housing, a pretty flat income structure, job, wage employment and unemployment insurance, lots of safety net services. There are still people experiencing homelessness, but they tend to be people with a very, very high level of individual vulnerabilities. In the United States, in 2020-22, the truth is you don't need very many individual vulnerabilities to experience homelessness. So there was a book that came out this year that's really fantastic called Homelessness is a Housing Problem by Colburn and Aldern. And they break homelessness down into the drivers or the systemic factors that create overall homelessness rates and explain the difference in rates between communities. These are really first among them, lack of affordable housing, but also things like income inequality and structural racism. And they contrast that to precipitants, or individual risk factors that increase the chance that any individual within a community becomes homeless. I'm from the Bay Area, where there's a lot of homelessness and a lot of very visible homelessness. And there is a lot of talk in the press and in sort of the Twitter sphere that this is because of, rampant drug abuse in problems in San Francisco. It's soft on drugs, it's this and that. But the truth of the matter is, as they point out, if you look at any tracking data on substance use, if you look at sort of things that we rely on, like the National Survey of drug use problems, if you look at reports of overdoses or other measures that we try to get a handle on rates of substance use in a community, substance use is substantially worse in West Virginia than it is in the Bay Area. But homelessness is 8 times as bad in San Francisco than it is in the Bay Area. This is not about substance use, or at least that doesn't explain why there's so much homelessness in San Francisco. And we'll talk a bit about what does. So I talked to them before they wrote this book, and I used this analogy, and it turned out I wasn't the only one. A lot of people did, and I love this analogy, but I feel like they perfected it. They talk about the homelessness situation and the difference between those two questions of why is there so much homelessness, or why is this person homeless, as a game of musical chairs. And if you guys know that game, kids at a birthday party, there'll be 10 chairs, 10 kids, they're walking around. The parent pulls away a chair, turns off the music, and the kids scramble for the 9 remaining seats. If a kid at the birthday party sprained their ankle playing soccer the day before, there's a pretty good chance that they're going to be the kid, when you pull away the chair, who can't get to the seat. So the question is, why is this kid standing as opposed to the other kids? That's because of their individual vulnerability. But here's the thing, the question of why is there a child standing? It's because you pulled away a seat. And if you had had 10 seats, they would all be sitting. And if you didn't have a kid on crutches, somebody else would be standing. And so this is really all about structures, is where the solutions are going to come from. It's all about returning that 10th seat and not worrying so much about why this particular kid is standing. So this is really why we have so much homelessness. In your state, you're doing a lot better than my state, and you're at the average for the country, which is, in the country, there are 36 units of housing that are affordable and available for every 100 extremely low income renter household. In my state of California, we're the second worst in the nation. We only have 23 units of housing for every 100 extremely low income household. And affordable and available means that the house is not rented by someone of a higher income, is habitable, and is affordable at less than 30% of a household's income, because if you're very poor and you spend more than 30% of your income on rent, you're not spending it on healthcare, you're not spending it on education, and you're at very high risk of becoming homeless because you have no savings. This is why we have so much homelessness. It would be irresponsible to have any talk about homelessness without talking about the role that structural racism plays in causing and perpetuating this problem. And just a brief reminder that in our country, home ownership has been the primary means of wealth building, and that until very recently in our history, there was legal discrimination in home ownership. It was unethical, it was immoral, and it was racist, but it was perfectly legal. And that was through measures like racial covenants, which didn't allow white homeowners to sell their house in a certain neighborhood to anyone who wasn't white. The banks, federally supported, federally insured banks, got into business and basically said, if you lived in a neighborhood that you didn't live in a neighborhood that white people were allowed to live in, that only white people were allowed to live in, they didn't have to offer you a mortgage, or if they did it at terrible rates. This left us with neighborhoods that we still live in. You can still trace the old red lines around the neighborhoods that we still live in. And this basically left Black and brown communities out of the post-World War II expansion in homeownership, and thus out an incredible amount of intergenerational wealth transfer. That is no longer legal since the late 1960s, but we know that discriminatory practices exist. You saw it in the predatory lending crisis in 2008, where Black and brown households were targeted for predatory mortgages and were much more likely to be foreclosed on. There's really good research done by Matt Desmond and others showing ongoing active discrimination in the rental housing market. So if you have the same rental resume, same number of evictions, income, number of kids, number of family members, and you show up to rent an apartment and you're a white family versus you show up and you're a Black family, you're much more likely to be denied the rent if you're a Black family. This means that Black households wind up spending a lot more money for a lot less good housing. You add to that the well-known and well-described discrimination in the criminal justice and employment systems and educational discrimination. And it's worth noting that we fund our public education system through local taxes. So formerly redlined Black and brown neighborhoods have a lot smaller tax base to support their schools. It's perhaps not a surprise that Black Americans are at 3 to 4-fold increased risk of homelessness. So exposure to racism becomes a very strong vulnerability, which is really a structural vulnerability, but it increases the risk for Black and brown folks to become homeless. In San Francisco, less than 5% of the population identifies as Black, and 37% of those experiencing homelessness do. So let's talk about the aging of the homeless population. First of all, it is aging. Some colleagues and I did this study we published it in 2006, that showed that the proportion of single homeless adults, those are homeless adults who are not parents in homeless families or homeless youth, who were 50 and older in 1990 was 11%. In 2003, when we stopped data collection, it was 37%. And now when we look at internal data, it's about 50% of the individuals experiencing homelessness in San Francisco are 50 and older. This is true across the country. My colleague, Dennis Culhane, who's a demographer at the University of Pennsylvania, read our study, sort of called me up, was like, oh, that's really interesting. I think I can go further. And he got shelter data from across the country. He focused on men because he didn't want to look at mothers and homeless families. And so he figured men in shelters are generally not in families. And he found that there was this big population bubble of people born in the second half of the baby boom. So if you look at that green line, that's 1990, and 1 in 8 individuals who were homeless then was 46 to 54. But if you look, there was this big bubble of people who were 31 to 33. When you looked in 2000, 1 in 5 folks were between 46 and 54, but there was this big bubble of people at the ages 40 to 42. And if you look in 2010, 1 in 3 were between 46 and 54, but there was this big bubble between 49 and 51. That big bubble, if you count back, corresponds to people born in about that 10-year period, 55 to 55 to 64, more or less. These are folks born in the second half of the baby boom. People born in the second half of the baby boom have a lot of disadvantages. The first half gets a lot of the jobs. Jobs aren't available for the second half. This was also a cohort that basically entered the workforce during a recession. And we know that people who enter during a recession never make up the lost income. They were the cohort that entered adulthood during the period of mass incarceration. So a lot, particularly of Black and brown men, had their lives really derailed by that. And importantly, and it doesn't get talked about enough, they were a generation that entered adulthood and entered the housing market right at a time when there was a large retrenchment in federal support for affordable housing. There was a big shift in policies that started in the late 1970s, but were really intensified when Reagan took office in early 81, that dramatically reduced the federal spend on affordable housing and really set this whole crisis in motion. Dennis's group has forecasted that this group of older adults is going to continue aging until about 2030, when the demographic winds will shift again. But he and his colleagues have estimated that the proportion of people experiencing homelessness 65 and older will triple between 2017 and 2030. So that turns me back to my research funded by the National Institute on Aging, a study we call the Health Outcomes of People Experiencing Homelessness in Older Middle Age, or Hope Home, funded by the NIA. It's a longitudinal cohort study that we've been doing in Oakland, California, a city in the East Bay of California. We enrolled 350 participants between July 2013 and June 2014. We followed them every 6 months. We recruited an additional 100 participants in 2017, 2018, and are recruiting another actually 200 this year. We just got the grant renewed again, and we'll be going back in the field. We're continuing to follow anyone who's still alive, whether they're housed or not, whether they're still homeless, but we're recruiting 200 new folks. To be in the study initially, and these are the data that I'll be presenting on, you needed to be 50 and older, English speaking. We are adding Spanish speakers in this wave. It's the first time that that age cohort of Spanish speaking folks experiencing homelessness had hit 50. So we didn't do it earlier because they, our community advisory board told us they're not there yet. Homeless by the federal definition at the time of enrollment. And then after that, you're followed no matter what your housing status is. So the federal definition called the HERTH Act means you're either living outdoors in places not meant for human habitation, people living in bus stops, living in abandoned buildings or sheds without plumbing, living in shelters, losing your housing within 14 days with no place else to go, or fleeing domestic violence with no place else to go. The study includes regular study interviews and exams. So we do neurocognitive exams, we do weight, vision, height, and then some balance testing. It includes qualitative interviews on topics of interest. So we've embedded qualitative interviews throughout the study and occasionally have different NIH grants to do it. And occasionally we just sort of embed it. We add new questions and adapt the study based on what our community advisory board advises us or questions that come up from policymakers. We have aggressive assessment of death records through both local and state death records, jail records, HMIS, which is the Homeless Management Information System. We do monthly check-ins to enhance follow-up, and we use what we call tracking activities. So we get extensive contact information on people. We don't see them for a month or two. We start looking for them. We outreach to where they might be. We have their photo, we show it around, we leave notes, we use word of mouth, we use social media, search engines, and we start to contact their contacts. We typically have about 75 to 80% of those who are alive attend every interview. And overall, we've had over a 90% follow-up rate, despite the fact that most people start the study unsheltered and homeless. When people have moved away, and a little more so during the pandemic, we've used phone interviews where we lose some of the ability to do the exams, but we at least keep the interview data. So at baseline, our median age of our study population was 57. The range was 50 to 80. Only 12% of baseline were 65 or older. 77% were men. This is in keeping with most data on single adult homelessness. 80% were Black in a city that was about 28% Black when we started the study. And 90% had a household income of less than $1,150 a month in the most expensive place in the country to live. At baseline, almost a third of our participants had lost what we called their stable housing in the past year. Stable housing is a more strict definition than when you became homeless. If you looked, about half had become homeless in the past 6 months. But stable housing is the last non-institutional setting where you've lived for a year or more. And you can see about 33% had lost it in the last year. You can see that 15% had last been stably housed more than 10 years before. I think in some ways this was what motivated the study in some ways, and the most important finding is Dennis and I had this long-standing conversation of like, so, okay, we get it, it's aging. We get it's the second half of the baby boom, but are these the same people who became homeless in their 30s and 40s and just stayed homeless? Or is there some ongoing risk related to this age cohort that keeps putting them into homelessness? And I think we kind of answered the question, which is that in our study, using a very strict definition, if anyone had even one night homeless at any point in their adult life, we counted it. So if you were homeless for one night when you were 19 and not again homeless until you were 55, you counted as first homeless before 50. But even looking so, 44% had never been homeless before the age of 50. Now remember, everyone in the cohort is 50 and above, so this isn't a statement of everyone who's homeless. But amongst those people who are 50 and above and homeless, almost half had never been homeless before the age of 50. We posited that those who were first homeless before the age of 50 would be different than those who were first homeless after the age of 50, and they were. sort of multivariable analysis. They had like more adverse life experiences, low income attainment in early adulthood, much more likely to have no spouse or partner, much more likely to have profound mental health problems, much more likely to experience severe traumatic brain injury, to have a history of imprisonment in state or federal prison, and to have an early onset alcohol use problem than those who became homeless for the first time after 50. This was one of my participants who we found in his mid-60s. He had been homeless on and off since his teenage years. And he is describing the day he first became homeless when he was a teenager. My father said, next time, if you run away, I'll beat you with a car chain, or I'm going to throw you out the window. Sorry. Slides are not advancing. Oh, there we go. Okay, so I wouldn't use the word reasonable, but I put things in perspective real quick, and I would say, could I survive a car chain? Probably not. Then I looked at the window and said, and we lived on the 13th floor. I said, I ain't playing with this man. He went to work. I had whatever I had on me, and I was out the door. He spent the rest of his life, we met him in his 60s, sort of in and out of shelters, encampments, incarceration, hospitals, and the like, and never really, after this really terrible childhood, never really had a foothold on sort of normal development or society. Those with late onset homelessness had very, very different experiences. They generally had lived quote unquote typical lives where they had worked in low wage, physically demanding jobs until sometime after the age of 50, they experienced either one or two crises. Those crises were either a job loss, their marriage broke down, they were ill, or their spouse or partner was ill, their spouse or partner died, or their parent died. Many instances of men in their 50s who had lived with their mom in a house that had been rented or owned in the family for generations. Mom dies, they have no title to the house, they get kicked out in a rapidly gentrifying area and find themselves homeless. We found a marked lack of advocacy, evictions for reasons that the landlords were actually not allowed to evict them for, but they didn't have access to any legal status, people who were not getting benefits to which they applied or to which they qualified for. Everywhere they went for help, they faced hurdles. They had a lot of very low measures of social support, but it wasn't so much that they didn't have family or friends. It was that they were so ashamed that they didn't access these. They were less likely to have an imprisonment or a long incarceration, but found that their housing was tampered by a one-time charge, a one-time drug charge, or an unexplained arrest that had happened early in their lives and really disrupted them throughout their adult lives. This was one of our participants who we met with his wife under the side, sort of under an embankment. The wife was blind and hemiparetic. She couldn't use half of her body. And they said it was a lot of different things, but basically talking about when they lost their housing, the new owner took over, we were being evicted. Sorry, it's not working. I think my Wi-Fi is not good enough. They basically said, so we went, my wife, she had just got out of the hospital. She had the stroke and was blind. So the daughter came up and said, don't fight it. Y'all can come stay with me for a couple of months and save your money. So we said, okay, and we didn't fight the eviction. After we moved out of the place, turned in the keys and everything, we went over to her house, to the daughter's house, and she said, y'all can't stay here. And I said, I've got $9 in my pocket. At least let your mother spend the night because we don't have enough money to get a motel room. She said, no. So that was the beginning. Her boyfriend had not wanted them to stay. They left the house with everything they had on them and went under an underpass where they lived. We found them there a few weeks or months later. They got housed a year later and the wife died soon after. Sorry. Get to the next slide. So that what we found was, sorry about this, guys. I'm not sure why I can't advance this. There we go. Well, those with late onset homelessness tended to have fewer vulnerabilities. Many had significant health challenges related to their homelessness. One of the ways we measure health or predictors of how people are going to do is simply ask them how they would rate their health: poor, fair, good, very good, or excellent. 56% rated their health at their first interview as fair or poor. By comparison, this is what we usually see in the oldest old, sort of 85 and above, not a cohort whose median age is 57. We hypothesized that chronic illnesses would be vastly underreported because people had poor access to care. But even so, they were really common. You can see that at enrollment, 7% had already had a heart attack, 7% had congestive heart failure, 14% had diabetes, 6% had had a major cancer diagnosis. We found that functional and cognitive impairment was extremely prevalent. More than 25% met criteria for global cognitive impairment. Actually, over a third met criteria for impairment in executive function, and nearly half had functional impairment measured by ADLs. We found a very high prevalence of all geriatric conditions: mobility impairment, falls 34% in the past 6 months, visual impairments, hearing impairments, and urinary incontinence. Just imagine trying to either rent an apartment, get a job, if you had no access to laundry facilities and you had urinary incontinence. This all leads me to say that when we're talking about the homeless population, 50 is the new 75. The median age of the sample was 57, but the prevalence of geriatric conditions were worse than we see of those in general population samples in their 70s and 80s. Substance use was common, much more common than age-matched populations, and dramatically more common than people in their 70s and 80s, which is probably the appropriate age match. About 2/3 met criteria on the audit and the assist of moderate or severe substance use. So using the assist, about 2/3 had one form of moderate or severe substance use indicator, 43% from cocaine, 13% from opioids, 8% from amphetamines, and 26% had moderate or severe alcohol use symptoms, 15% with severe symptoms. Mental health problems were common, but were commonly what's common in the general population, with depressive symptoms, moderate to severe, affecting over a third, possible PTSD in about a third. About 17% had ever been in a psych hospital, but about 5% had been in a psych hospital in the prior 6 months. Perhaps this is the Bay Area. It was during the Obamacare rollout where California had, a massive expansion of Medicaid. We have a very robust safety net. So the good news is 72% of our participants at baseline, even though a Medicaid expansion was just rolling out, were able to name a clinic that they sought care at that was not the emergency department. And actually 53% at baseline were able to give us a name of a primary care provider. Despite that, half of all of our participants visited an ED in the prior 6 months, and fewer than 7% of participants accounted for half of all the ED visits. So a small group of people using it again and again. And 10% reported a hospitalization for a physical health condition in the prior 6 months. Again, very, very high numbers. This was right 2 days ago, but unfortunately we've had another death. We've just had our 130th death. We've had now 130 of our original 450 cohort participants have died. Sometimes we have a little bit of a lag in finding out, so I suspect the true number is a little higher than that. This accounts for over 29% of our cohort. And the median age at death is 65, ranging from 54 to 77. Remember, everyone had to survive to 50 to enter this cohort. We recently published a paper in JAMA Internal Medicine looking at deaths through the end of last calendar year. And what we found were the rates when we looked at age and gender matched rates to Oakland itself were 3.1 times greater than the general population for men, and 5.2 times greater comparing to the general population for women. The leading causes of death were heart disease, cancer, and drug overdose, with heart disease and cancer a little bit more common. While the rate of death dramatically increased, we're sort of working on this now, but it looks like there was an inflection point in March of 2020 where the rate of death dramatically increased. The causes of death were not really directly attributable to COVID. 3 people died with COVID on their death certificate. We looked at factors associated with dying, and we found that group who was first homeless at or after age 50 had an elevated hazard ratio of death compared to those who were first homeless before 50. all in this cohort. And we found that those who remained housed were much more likely to die. Were much less likely to die. Those who became homeless were much more likely to die or stayed homeless than those who regained housing. Any form of housing was associated, at least in this model, with a pretty dramatic reduction of the hazard of dying. You can see that dramatically elevated hazard ratio for staying in a SNF in the prior 3 months. It shouldn't probably say jail, it was just SNF. But that's because many people in our sample are sent to SNFs in lieu of hospice care. That's the only way they can get hospice care. Diabetes was associated with a risk of death, as was self-report of fair or poor health. So I'm going to back up now and just talk a little bit about how we did this and how we have such good follow-up rates. And I'll tell you what I think our secret sauce is. One is at least half of our staff have lived experience of homelessness, and they match in many ways the characteristics of our participants. I have found that it's much easier to teach someone who's had late life homelessness how to do consent, how to use REDCap, how to do interviews, than it is to teach like a really brilliant, wonderful graduate, but whose life experience is very different from this, how to relate to participants who are experiencing homelessness. We have had a very active and involved community advisory board from the day we started. We'll say when we wrote the grant, our advisory board just consisted of policy and programmatic leaders, people who like executive directors of big programs, policymakers, and the like. But as soon as we started to enroll people, we started to recruit participants for the advisory board. If I were doing this again, I would have sort of potential participants as part of the advisory board from the very beginning. But now they've been with us since about 2013, and their insights have been absolutely key. They generally come up with the ideas for our next papers and our next grants. They help us write our questions. They help us make meaning of our findings. We had to convince the NIH that we needed more funding. Didn't necessarily give it, but we were sort of asking for more funding because however you do it, it takes a lot of time to lessen missed visits and missed data. Our staff spend at least half, if not more, of their time looking for people as they do interviewing people. The interviewing people is the easy part. It's what they're mostly spending their time on is tracking people down, looking for where they go. We capture whatever data we can, even if it's not complete. If someone is too upset to complete an interview, we'll stop the interview, but we don't throw out whatever data we had. Some people, can only give us a couple minutes. We take what we can get and we use what we have. We think through missingness and how to deal with it ahead of time and constantly. We've had to do a fair amount of secondary trauma work for staff who are exposed day after day to these stories, to this suffering that many of them have personal experience with, but it's really heavy. And so we pause and we bring in outside folks, we do trauma work. We have very strict protocols in place for mental health and other emergencies. There have been shootings. There have been people calling with suicidality and other things. And we've had to give a lot of thought for probabilistic matching when we try to match, because sometimes people use fake names or they'll do their birth date exactly. And so we're trying to use best practices to use probabilistic matching when we're like matching to state. Like, for instance, every year we get a download of all the deaths in the state. So now I want to turn back to a little bit of like how we get ourselves out, of this, this mess. And the first thing to say is the solution to homelessness is right there in the name. If homelessness is the problem, homes are the answer, right? The solution to homelessness is housing. And Housing First is the evidence-based way to do this. Housing First is not a program, it's a philosophy, which says that you start with the housing and you don't require services, you don't require treatment, you don't put a whole lot of requirements. You start with the housing, and that is a foundation for everything else. I like to say that everybody needs housing. Some people require services, some people require a lot, some people don't require services. They just need a house that they can afford. Housing must be affordable when we're talking about folks in the ELI group, which is who I'm talking about. What's most important is that it's affordable at less than 30% of the income. ELI housing is where the action is at. Even affordable housing, which we don't have enough of, won't really solve this problem because most affordable housing is targeted towards people who make between 60 and 100% of the area median income. And all the action in homelessness is people who make less than 30% and sometimes less than 20%. So we need to expand and preserve affordable housing. And we need to focus on ELI housing. This is a really great source of information as a national low-income housing coalition. Here's some data from Michigan. In Michigan, 28% of renter households are extremely low income, and the state of Michigan is short 200,000 units of ELI housing. California, we're short 1 million units, so you're doing better than we are. You can see that 71% of those ELI households in Michigan pay more than half of their income in rent. That's the definition of severe cost burden. So how about those with really bad, behavioral health challenges, with bad substance use, mental health problems, long histories of imprisonment? A lot of people say to me, well, you can't just give them an apartment. And I would say you can, and you kind of have to. That's the answer. And we've shown it in randomized control trials. We've shown it in quasi-experimental studies. We've done a whole bunch of work on this. It really works. You use something called permanent supportive housing, which is just a housing first model. You give subsidized housing, link supportive services, and you need those supports to be there for this impaired population. But you start with the housing and you don't require the services. And what we've shown is you don't require them. They're not mandatory. People don't have to earn their housing. You just take them into the housing and then you wrap the services around them that make them perfectly voluntary. People take them up and they sustain their housing. We are going to need to adapt these for the needs of older adults, which are different. And I think the industry is not really prepared for it. Many older adults who are homeless don't actually require PSH. They don't need all these supports and services. They just need housing that they can afford on fixed and limited incomes. We need to get more expansion of housing choice vouchers. Right now, only 1 in 4 households who qualifies receives one. We need to lean into things like senior housing, where there's certain funding lines in the federal government for it. We're looking into the role of shared housing. Can we match people or have them choose a roommate? And would that bring down the cost and make it more viable? And we desperately need to reduce, protect, preserve ELI housing, and we need to focus on prevention. So homelessness is reaching crisis proportions. The aging of the population increases the urgency. The suffering we see is really immense, and the use of the healthcare system can be chaotic. And while mental health and substance use disorders are common, the underlying causes are structural. Everybody needs housing that they can afford. Some need housing, some need services in addition to that housing, but everyone needs a housing. And we need all housing, whether PSH or otherwise, to be age-friendly. I invite you to join me in my tagline as a physician, where I say there is no medicine as powerful as housing. And with that, I will stop and take any questions or comments.